Yes, sir, we are live now.
Hello and good evening. And this is the eighth lecture and the final lecture in the series of clinical cardio class for the 3C of young cardiologists. Myself, Dr. Kamal Sharma, faculty cardiology at UN Mehta Institute of Cardiology and Sal Hospital. Along with me is Dr. Jemajan. And today we have an expert, Dr. Tom Devasya who's a professor and unit chief of the Department of Cardiology at KMC Manipal. Dr. Tom, welcome.
Thank you very much for your invite. I'm very happy to
And
be here with you all. Looking forward to an exciting session of learning and teaching. Thank you very much.
Thank you very much. And also, we'll have Dr. Ajay Mahajan, Professor, Head of the Department, KEM, Mumbai. Today, we have case presentation on prosthetic valve dysfunction, and this is going to be presented by Dr. Prernagar from AIMS, New Delhi. As we know that this is an important short case presentation in a lot of clinical cases with increasing valve pathologies, and so also more and more valve implantation. This is the disease that often comes back to you. As Denton Cooley once said, replacing a valve with a prosthetic valve is like replacing one disease with another on the lighter note. So, prosthetic valve dysfunction is a disorder that very often we all, as a clinical cardiologist, will have to entail. And that's one of the important clinical short case spotters or a short case that is often asked. The Viva can, of course, go into the extent of indications, types of valves, how to evaluate, and we'll be learning as we go ahead. So, Dr. Prerna, if you're there, I invite you. We have 1 hour of interesting case presentation and discussion with faculty from expert faculty like Professor Dr. Tom Devasya and also Dr. Ajay Mahajan joining myself. And we'll also have faculties from ACMP, who's the academic partner for this meeting. So, and after that, we'll have the expert talk from Dr. Tom, who will be taking us through important spotters that are very often asked in exams. Very interesting talk, and we thought spotters is the last thing that we discussed in tables after the end of a long and short case, and that's how we scheduled it. So, Dr. Prerna, if you can share your slide deck, if you're prepared for the case presentation.
Good evening, sir. Thank you for allowing me this opportunity.
Most welcome, Prerna.
Today, we'll be discussing a case of a 66-year-old female. She's a retired hospital attendant from Delhi. The patient, who has a significant history of aortic wall replacement in 2016, presented to us with complaints of shortness of breath for 3 days and exertional chest pain for 3 days. She was in her usual state of health till 3 days ago when she developed shortness of breath, which progressed rapidly from shortness of breath while climbing stairs to even when walking 100 steps. It worsened with lying down. It was not associated with any ancillary symptoms like cough or sputum production, and she did not give history of PND in the past 3 days. This was also associated with significant exertional chest pain. She described it as retrosternal heaviness, which also progressed from climbing stairs to even when walking 100 steps. It was relieved on rest. It never occurred at rest or lasted for more than 10 minutes. It was not reproduced by palpation. It had no relation to meals, and the patient did not describe any radiation. The patient did not take any medication for it. There was no other history in the form of dizziness or fainting. There was no history of swelling of feet or elsewhere. There was no history of palpitations. The patient denied any history of intercurrent infection in the past few days, any history of non compliance to medication, or any febrile illness. The patient was on oral warfarin 7.5 mg once a day, but her last INR was done more than 6 months before presentation. The patient had history of two similar episodes in the past. The first episode occurred in 2018, 2 years after the index surgery. The patient had stopped taking blood thinners on her own due to oral bleeding. She had similar complaints at that time. She was told she had a valve blockage for which multiple doses of an IV medication were attempted to relieve the blockage. Finally, this was unsuccessful and the patient was taken up for redo surgery. She said that in the redo surgery, the blockage had been removed, but the valve had not been changed at that time again. After that, she was asymptomatic till March of this year, March 2024, when again she developed similar complaints. At this time, she was compliant to medication. She was again diagnosed with a block in the prosthetic valve and was given IV medicine. At that time, the IV medicine was successful and she became asymptomatic following that. The patient presented to us to the emergency with the above complaints, where she underwent basic tests including ECG, echocardiography, and a cine fluoroscopy. She was told at that time that she had recurrence of the same complaint and she was started on IV medicine. She has till date received 4 cycles of the same medicine, which she receives as a slow IV infusion over 6 hours. She was also started on some medication, some IV medication to increase her urine output. She reports significant improvement in symptoms following this medication, but is still in hospital, so her exertion is limited to visiting the washroom. While in hospital, she has undergone multiple blood tests and a CT scan for the heart. And she was told that her INR at presentation was subtherapeutic, it was 1.45. In her past history, this is the history of the index complaint that she had. The patient had progressive shortness of breath, exertional chest pain, and episodes of exertional dizziness from the age of 45 to 50 years, approximately from 2000. She had undergone evaluation at our hospital and was told that she had an abnormal valve by birth, which had now become shrunken. The other valves were told to be normal. She was advised a valve replacement, which she underwent in 2016 at the age of 58 years. She has no other significant past history and no comorbidities in the form of diabetes, hypertension, or any history of TB. She takes a mixed diet and is aware of warfarin dietary restrictions, but is often not compliant to them. She has a normal appetite and does not complain of any weight loss. She has no known addictions or allergies. She has no bowel or bladder complaints at this time. She is postmenopausal and achieved menopause at the age of 45 years. Prior to that, she had normal cycles. She had 3 children through normal vaginal deliveries done at hospital. She did not complain of any complications during her pregnancy and was not diagnosed with any cardiac disease at this time. She belongs to the lower middle class and lives in an apartment with her son, daughter-in-law, and their children. There is no overcrowding present. To summarize the history, the patient is a 66-year-old female with a history of aortic valve replacement in 2016. She presented to us with complaints of NYHA class 3 dyspnea and angina for the past 3 days. There was no history suggestive of any ACS or any intercurrent infection. She did have history of similar episodes in the past, which initially she underwent redo surgery for, and the second time probably underwent thrombolysis.
My question is,
Yes, sir.
your angina since last 3 days and you are telling there is no history of ACS.
Yes, sir.
So you have to explain this particular thing.
So she has angina, which is suggestive of a stable angina. It is not suggestive of ACS. There is no crescendo pain. There is no pain at rest. There is no pain which has lasted for more than 10 minutes. The pain at every time has occurred with exertion and is relieved by rest. So she does not have any history suggestive of ACS. She does have history of increased angina, which may be related to a coronary artery disease or an obstruction in the aortic valve.
Only 3 days. You are specifically telling only 3 days history of angina.
Yes, sir.
So if there is only history suggestive of 3 days angina, then most of the time it is
Yes.
ACS or unstable angina.
Yes, sir. So that is one of the things that we have to rule out in our evaluation based on her which is why probably she underwent an ECG at presentation. Even in patients of prosthetic valve, they may suffer an ACS due to thrombosis from the valve despite being on anticoagulation. But she did undergo an ECG in the emergency, followed by an echo and cine fluoroscopy, and she was given IV medication over 6 hours. She was not advised any revascularization therapy, which makes it unlikely that she suffered an ACS in this episode. So should I
Yes, please continue.
In this presentation, she had subtherapeutic INR. After evaluation, she was likely started on thrombolysis and diuretics, following which she had significant improvement. So should I move on to the examination?
So in this, you told about patient had orthopnea,
Yes, sir.
but no PND.
Yes,
Is
sir.
it okay? Is it unexpected or is it expected?
So usually patients complain of PND before orthopnea.
So why
indicates
this patient did not have?
Sir, it indicates increased pulmonary venous hypertension. In the setting of raised LVEDP, it is likely that she had both. It is possible that she was not able to lie flat for long enough or had significantly disturbed sleep because she was quite sick in the past 3 days. But I specifically asked her for history of PND, that she would wake up after 2 to 3 hours of sleeping and walk around or have to get up, and she denied it. So.
You're right, and her history is also right. So when there is rapid progression of dyspnea, there is
Yes.
no time for PND to develop. They straight away go to orthopnea.
Okay, sir.
Yeah. So how do you know at present she had subtherapeutic INR? How did she explain to you?
So she knows her INR. She's a hospital attendant who was retired from our hospital only. So she knows she's on warfarin. She knows she's supposed to get it checked regularly. She she knows about warfarin diet as well. She said she had not gotten it checked for the past 6 months, and she had not since her last hospital visit. And this time when she came, she categorically said it was less than 2 also. It was 1.45. She knows the value, sir.
So closely associated with hospital and she checks once in 6 months. Huh?
So she's elderly now, sir. I feel that is why she has become less compliant.
So how often you are supposed to check the INR?
Sir, so when we start the patient on warfarin, we start checking every 3 days, and then accordingly we perform dose adjustments. Once we reach a state, once the value reaches more than 2, we can check once weekly, and once it is stable, we usually advise at least monthly checking on an outpatient basis. However, in the setting when the patient has missed a dose or has had an infection or has taken additional antibiotics or other drugs, we advise to check more frequently because those drugs may interfere with the anticoagulation.
Yeah. So how often, you give unfractionated heparin injection along with initiation of warfarin. Why first few days?
Sir, because warfarin inhibits protein C and protein S production also, so it initially causes a hypercoagulable state. So it initially we need to overlap with UFH or low molecular weight heparin to prevent thrombosis.
So, yeah. So you said this patient had subtherapeutic INR and you had an option of thrombolysis, and the other option is what?
Sir, so we have 3 options. One is continuing medical therapy, which is not advisable in this patient because she's acutely sick. Second option is if we are proceeding with an intervention, we can either do thrombolysis or surgery, and rarely percutaneous interventions have been tried, but they are still in investigational stage. In patients, so based on the clinical presentation, we take a call for redo surgery or for thrombolysis. In this patient, in the setting, in acutely sick patients or patients with large thrombi, which can be visualized, it is preferable to do surgery. In this patient, however, we have significant history that she has passed redo surgery also, which would make redo surgery difficult. She is quite elderly. Her age is 66 at this time. And she has recent onset angina, which indicates it might be a fresh thrombus. So a trial of thrombolysis was given to this patient, sir.
Yeah. Also, it is very important that you write a surgical consult first before you proceed with thrombolysis and explain to the patient the 20% risk of stroke.
Yes.
Because in prosthetic valve dysfunction, as you already know, stroke, if it is a disabling event, it can cause a lot of problems.
Yes, sir.
Yes.
So should I proceed
Why
with?
do you think this patient had angina along with the dyspnea?
Such significant aortic valve obstruction can cause exertional angina also. She has presented to us with an aortic stenosis phenotype, sir, where there is obstruction to aortic outflow. So she has developed raised LVED, which has caused dyspnea. Her cardiac output is probably not able to compensate when she exerts, which is causing the angina.
Any other possibility you would consider?
Sir, ACS would be a strong possibility that we should consider first in all such patients, for which an ECG and a troponin would be advisable. If
So how do you correlate an ACS with a prosthetic valve dysfunction?
Sir, coexistent CAD can anyway occur with advanced age, but prosthetic prosthetic valve thrombosis per se is a risk factor for ACS because the microthrombi may dislodge and go into the coronary arteries.
Yeah, it can be an embolic event
Yes.
causing ACS. So you said that she was having from birth, you said congenital, right?
Yes, sir.
So despite being congenital, why do you think she had no diagnosis made and no symptoms during pregnancy and delivery?
Sir, most likely she had a bicuspid aortic valve, and which had progressively become stenotic. Her presentation is slightly later, is in line. She became symptomatic around 45, 50 years. So usually, bicuspid aortic valve, which in early 20s and in early age presenting would be more likely regurgitant, and with advanced age in 30s and 40s in the third and fourth decade would present with stenotic symptoms. Most likely, she has presented to us with aortic stenosis, probably based on her symptoms. She started developing symptoms around 45, 50, which means her valve area would be significantly reduced by that time. And then she was advised the valve replacement, sir.
So according to you, let me be a little bit descriptive. This patient with aortic valve dysfunction, when they have aortic valve dysfunction, do you think it is stenosis, regurgitation, or both?
Sir, usually it is both, sir. Initially, it is regurgitation, then they develop stenosis as well.
Usually they both happen together because a valve, when it gets stuck, both ways it can malfunction.
Okay, sir.
Okay,
Okay.
please continue. Next slide.
On
What
examination,
is your provisional diagnosis? Usually we keep a slide for a provisional diagnosis from the summary so far. So what is your provisional diagnosis?
sir, in this case, my first differential would be a prosthetic heart valve thrombosis of the aortic valve. In the setting of a recent thrombosis nearly 9 months ago, I would also like to rule out a pannus in the aortic valve, which has predisposed her to this event. My second differential would be an ACS, which clinically should be ruled out as the first at presentation. So these are the top differentials.
So
And
there is
what do you mean by time in range
Sir,
or TTR, time in therapeutic range?
yes, sir. Sir, they say that it is adequate anticoagulation if the patient is in therapeutic INR for more than 80% of the time.
So how often do you do that?
Sir, we usually, once the INR is stabilized and the patient is on a stable dose, we usually ask them to do monthly INRs. In most studies as well, monthly INRs have been tested, and patients who are in therapeutic range for more than 80% of those tests are considered to be in therapeutic INR.
What is the role of aspirin in preventing the same?
Uh, Sir, currently aspirin is not advised for prosthetic heart valve for prosthetic heart valves. However, it is still given at a lot of centers.
So why do you think the aortic valve is replaced? Patient told specifically?
Yes, sir.
Okay, that's good for you. So let us see. So your provisional diagnosis is congenital bicuspid aortic valve. Underwent surgery, the year you have to mention. Okay.
Yes, sir.
Redo surgery year you have to mention.
Yes, sir.
probable prosthetic valve thrombosis with suboptimal INR, ACS cardioembolic. Correct? Anything else you want to add
Sir, ACS,
from the history alone?
yes, sir, to rule out ACS and to rule out a PANIS, sir.
PANIS is a different topic in the sense you have to see the reason for prosthetic valve thrombosis that we will discuss. So,
So my
what
question
are
is,
the
when the redo surgery was done, what is the duration from this episode from the redo surgery?
Sir, around 6 years now.
So redo surgery was done 6 years back.
Yes, sir.
And what was the index surgery?
8 years ago. 2016 was the index surgery.
So after index surgery, only after 2 years there was a redo surgery.
Yes, sir.
Okay, and what was the surgical notes at that time?
Sir, the patient said that only the valve, only the block was removed and the valve was not replaced. I did look at the surgical notes. They have only done a thrombectomy. They have not done a redo AVR.
Okay. Then PANIS is possible.
Yes.
So, what are the etiology-wise reasons for prosthetic valve dysfunction?
So there can be multiple causes for prosthetic valve dysfunction. The valve per se can be small, that is patient prosthetic mismatch. The valve can have ingrowth of new tissue, that is formation of PANIS. There can be thrombosis at the valve, which can cause either stenosis or regurgitant lesion.
Few other causes.
Um,
Sometimes the suture material can give way.
So there can be ring dehiscence or rocking motion of the valve where the suture material has given me, sir.
Good. Sometimes there can be infective endocarditis
There can
of
be,
the prosthetic valve.
yes.
So from these etiology, if you keep in mind, you know which are the ones that will present abruptly, dramatically, and what are the ones that will have a slow presentation. So your patient had an abrupt presentation. So what are the etiology you will consider?
Sir, my first differential would be a prosthetic heart valve thrombosis in the setting of an acute history, no history of any prolonged fever prior to this, and the treatment she has received. The second differential would be infective endocarditis, which should be ruled out based on echo and blood cultures and ESR CRP.
But
PANIS
no fever, right?
no fever, sir. PANIS
Good.
ingrowth, sir, should be ruled out in the history of recurrent aortic valve thrombosis that she has gotten. PPM is less likely
Yeah.
because she was asymptomatic in the intercurrent period.
Yes. So most likely the commonest cause is a PANIS with a superadded thrombus, especially after many years. But if it is within a few weeks, it is obviously only thrombus.
Yes, sir.
And suture material giving way can happen with an abrupt presentation also.
Yes,
So these are the possible etiologies, right?
yes, sir.
So with this in mind, let us proceed with the examination, if that is okay with Dr. Kamal and Dr. Mahajan. Yes, go ahead.
On examination, the patient is comfortably lying down on her bed. There is an IV cannula in place on her left arm through which an infusion is ongoing. She is conscious and oriented to time, place, and person. Her height is 154 centimeter, weight is 52 kg, which makes her BMI 21.9. Her pulse is 68 beats per minute, regular. There is no specific character. It is palpable in all four limbs. There is no radial, radiofemoral delay, and the vessel wall is not palpable. Her BP is 108 by 74 in her left upper limb and is similar in all limbs. Her respiratory rate is 20 beats per minute, thoraco-abdominal. Her saturation is 98% and she is afebrile at this time. Her JVP is not raised, X and Y descents are noted and are normal. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or any peripheral edema. There is bruising present on both her arms at the site of sites of previous cannulation and blood sampling. Her dental hygiene appears adequate. There are no caries. There are no peripheral signs of IE or aortic regurgitation noted. On cardiovascular examination, a central sternotomy scar is present. The trachea appears to be in midline, and apex is seen in the fifth intercostal space medial to the midclavicular line. There are no visible pulsations or dilated veins. On palpation, the finding of inspection is confirmed. The apex is localized to one intercostal space. It is heaving with presence of medial retractions. There are no palpable thrills or heaves. There are no palpable heart sounds. On auscultation, her S1 is normal. The metallic click of a prosthetic heart valve is heard as the S2. There is an ejection systolic decrescendo murmur, which is heard loudest at the Erb's point at the third left intercostal space. It is heard best in leaning forward position with the breath held in expiration. It is radiating to the apex in a sash appearance. There are no other murmurs or added sounds. Her examination of other systems is not significant. Her respiratory system shows bilateral air
Please
entry.
go back one slide, please. Thank you. Okay, so you think from line 2, what are your inferences?
Metallic.
Click
Yes.
of prosthetic heart valve. What are your inferences from that sentence?
So there is a aortic there is an aortic prosthetic heart valve, which is so we can tell that there is a click, so it is not stuck in the open position, but we cannot say if there is any stenosis. Further, we cannot rule out, we cannot put thrombosis in this because we have to ask the patient if there is any change in nature of the click noted.
Okay, so the first thing is metallic click. So it is a mechanical prosthetic valve.
Yes, sir. Yes, sir.
Okay.
Yes, sir.
And it is corresponding to the second heart sound. So that means it is a
Aortic.
it is a
Aortic
yeah,
valve.
it has to be aortic or pulmonary. So let us presume it is aortic. Now, how do you differentiate the different types of mechanical valves based on the clicks?
So,
Very important in evaluation of mechanical prosthetic valves.
sir, so there can ball and cage valves used to be used, were historically used. There is an ejection systolic.
Okay. Let us see that. Okay. So is this a ball and cage valve? Why?
Sir, it has been put 8 years ago, at which time tilting disc valves were present, and disc valves were present. So most likely this is not a ball and cage valve. There is no ejection.
We don't know. We have to say based on the auscultation.
So there is. They also present with. They also have They have mainly an ejection systolic murmur, which is heard, sir. When the ball moves downwards, it causes a turbulence to the forward flow across the valve.
So the clicks are well heard. That means the valve is somewhat functioning good now. And the
Yes.
patient is asymptomatic. That means it is good news for the patient. And whatever treatment you have done so far is working well. That's good. And in ball and cage valve, there is opening click and closing click. Which is louder?
Sir, I'm not sure, sir. Opening click
Yeah,
should
it's
be
usually
louder.
opening click.
Yes, sir.
Yeah.
Because it would be
What are the
again.
other types of mechanical valves?
Sir, bileaflet valve, tilting disc valve.
Correct. Disc. In disc, bileaflet or tilting disc valves, which is the louder click?
So closing click will be louder in them.
Closing sound will be louder. So you should have described clearly during your auscultation and try to find out, because that is the only thing. Try
Yes.
to find out if it is a mechanical valve, where is the location, what type of valve, whether it is a ball and cage or tilting disc.
Okay, sir.
Okay.
Yes, sir.
And from the third line, what is your inference?
So there may be physiological flow murmurs, which are systolic murmurs, may normally be heard in prosthetic heart valves. However, this is a long murmur, which is radiating to the apex, so it likely indicates some degree of stenosis at the aortic valve. It did not extend into this. it did, sir, it did not extend into the second half of the systole, which is why I'm not convinced that she has severe aortic stenosis at this time. But there is some stenosis, there is some obstruction to the forward flow.
So let us say there is no significant obstruction versus significant obstruction to the forward aortic flow.
Yes, sir.
How do the two murmurs differ?
Sir, the most important thing would be length of murmur and where it peak, time to peak. So a murmur peaking in the second half of the stole would likely indicate a significant aortic stenosis, sir.
Okay, late peaking is correct.
Yes,
You
sir.
have not mentioned grade of the murmur. It is a problem in DM exam if you do not mention a murmur correctly.
Yes, sir.
What is the grade?
Sir, 3/6 grade.
Okay, so this is according to you a flow murmur or an organic murmur?
Sir, it is most likely an organic murmur, sir.
But no late peaking. You could not appreciate it, is
No.
it?
Yes, sir.
And if the valve is dysfunctional, you usually will hear, you are supposed to hear some regurg murmur, right?
Yes, sir.
Did you hear any regurgitation
Not-
murmur?
Sir, I specifically auscultated for regurgitation murmur. There was none.
Yeah, it is unlikely it is there. Because if it was there, then the valve is still dysfunctional and the patient will be really sick.
Yes,
And
sir.
when the patient is sick, there will be a lot of pulmonary edema and creps, and actually you will not be able to hear the
Peak.
diastolic murmur. Okay. It is radiating to the apex.
Yes, sir.
What is your inference?
Sir, an aortic stenosis murmur usually radiates to the apex, sir. It radiates in a sash configuration. So this is in line with stenosis to forward flow, sir.
Okay, the prosthetic valve murmurs, we cannot actually extrapolate always to the organic aortic valve disease.
Okay.
So, what is your inference from this auscultation?
So that there is a metallic valve which is placed at likely the aortic position, which has some obstruction to forward flow, which is causing a murmur. There is no regurgitation murmur heard. So we cannot. So that likely there is no regurgitation.
And the obstruction is not severe according to you.
Yes, sir.
Go back one slide, please. You have not mentioned about cardiac borders. Is there any cardiomegaly on palpation?
Sir, the apex is in the fifth intercostal space. It is medial to the mid-clavicular line. It is
Is
localized.
there any cardiomegaly?
No, sir.
That is very unusual because very often when there is a prosthetic valve dysfunction, there is acute heart failure and there is acute cardiomegaly when the patient is decompensated. And when you lyse, the cardiomegaly may come back, but first symptom relief and cardiomegaly recovery is not quick.
Yes, sir.
So that is a bit confusing. Yeah. And what about the pulmonary area? Did you percuss?
No, sir. I did not do percussion, sir.
Why? Any particular reason?
Uh, Sir, we don't do percussion in cardiovascular examination. It's not.
But when you're a PD, you should do. You should percuss for. Otherwise, how will you identify the right atrial enlargement? You have to percuss and identify the right heart border corresponds to the right sternal border or beyond it. What is the importance of percussing pulmonary area?
Not sure,
If
sir.
there is pulmonary hypertension, the pulmonary
And the
area will
artery
be
will be enlarged,
So
sir.
second left intercostal space. Causes of dull note include dilated PA, dilated LA, or pericardial effusion. Three differentials.
Okay, sir.
And also it will establish the situs. How do you establish situs solitus and it's not a dextrocardia or a levocardia, or what are you dealing with? So percussion is important for two important aspects. One, situs and cardia, which is very important in the congenital heart. and so also for the second pulmonary, as Dr. Tom is asking you.
Okay.
Those two things, and of course the RA, that's the third thing. So percussion, though they say obsolete, three things still do matter. Dr. Tom, you were saying.
Yeah, thank you very much. And I'm a little bit surprised that you did not come across any additional chest wall uh, pulsations, because very often these post-op status with the valve dysfunction recent history, they usually have some abnormal pulsations in the chest wall if you observe carefully. So please go back and examine. This looks more like a casual Sunday morning rounds kind of examination to me. Okay, for your DM exam, you should be very focused and examine in detail.
Yes.
Because after DM, you are all busy consultants and your chances of a close examination is not there. So
Okay.
whatever you learn these time, that is all that stays with you. After that, nothing stays.
Okay.
Yes, please move forward 2 slides. So according to you, other systems are all fine, right? So you should give special focus on central nervous system, because there is a good chance that this patient underwent lysis, that is successful lysis causing a resolution of symptoms, and at least a majority of the thrombus dissolved and embolized distally, and we want to know whether it is embolized to the central nervous system. Anywhere else is of no much clinical consequence. So it's very important. Second thing, I expected this patient to have some basal crepitations, because patient was NIH class 3 with heart failure and hopefully no cardiogenic shock, because patient did not have any syncope or giddiness. So it is probably just pulmonary edema, and we expect some relief of pulmonary edema with thrombolysis, but we do not expect totally no Krebs. I expect this patient to have some basal Krebs, but maybe the treating doctor has given a good dose of diuretic so that the Krebs totally vanished. And you are sure that there was no JVP also, right?
JVP is also not raised. So she's undergone 4 cycles of thrombolysis at this time over the past 6 days. So she is quite dry, sir. There is
So
no.
how much is one cycle of thrombolysis
So
according to
usually
you?
we give it so there are multiple regimens of thrombolysis that we can try. Slow and ultra slow regimens are usually used in contemporary practice. Slow is over 6 hours and ultra slow is over 24 hours.
So you did 4 cycles of slow or ultra
So
slow?
25 mg over 6 hours. Slow thrombolysis, she has received 4 cycles.
Which drug?
Uh, Altiplase, sir.
Multiplace.
Yes.
Last
So
time
what are the
during
agents
lysis.
that? Sorry, sir. Go ahead. Go ahead.
No, please go ahead. It's good. Please ask.
Yeah, we have. So what are the other drugs that you're aware of, and what are the data sets about using alteplase as costly therapy? So
So
any other drug?
So streptokinase, urokinase, altiplase, and now tenecteplase all are being tried. All have been tried in prosthetic heart wall thrombosis. Uh, Usually now we prefer to use altiplase because it is thrombin selective. It has higher efficacy and it can be used over slow regimens. There are currently trials ongoing on tenecteplase, which is a very rapid regimen which can be given over half an hour.
Which is the thrombolytic agent with maximum data?
So probably streptokinase or urokinase would have more data.
Urokinase, not urokinase, no, streptokinase. Yeah. So you
India,
use with
it's
all
all strepto. Everyone uses streptokinase. Though, what is
yes.
the disadvantage?
So after you use it once, the patient will become resistant to it, so you can't use it multiple times.
No, the problem is systemic lysis. No,
Systemic.
not a selective agent. That's all. Yeah, and you can use it, of course, beyond 6 months to 6 days. That's how the window is. You can't use it in 6 days. You can't use it beyond. Within 6 months to 6 days. You can use it beyond or before you develop the antibodies, and after the antibodies have disappeared.
Okay.
So
Yes. So next slide, please. Bicuspid aortic valve. This is your final diagnosis, right? So you have written bicuspid aortic valve. You have forgotten to write congenital.
Yes, sir.
Congenital aortic valve disease is very important.
Yes, sir.
Maybe it is bicuspid. We do not know. We'll presume it to be bicuspid. How do you know your indication for AVR was severe AS? We don't know. It could be severe AS or a combined AS-AR. We don't know. So please don't write.
Sir, based on her,
Post-op aortic,
sir,
based on her?
her apex was heaving. It was not, there was no evidence of cardiomegaly. It was not shifted down and out. So I felt that
Please
my
go back your slide and show me where you have written heaving apex.
so fifth intercostal space medial to mid-clavicular line and localized heaving with medial retractions.
Oh, yeah, that's good. So tell us about the reasons for a heaving apex in this patient.
Uh, Sir, heaving apex indicates that there is a slow uprise and which is persistent in during the systole. So it is usually related to obstruction to the outflow. So there could be aortic stenosis, any prosthetic valve dysfunction, not a regurgitant lesion, a stenotic dysfunction like thrombosis, PPM, pannus could all cause a heaving apex. This patient likely has a heaving apex because of concentric hypertrophy that she developed during her initial disease. Also, she had AS.
Yeah, so it reflects an LV outflow tract obstruction. Okay. It
Yes.
could have happened because of this prosthetic valve thrombosis. We do not know. We cannot say it is a reflection of a severe aortic stenosis for which she was operated on. So we
Okay.
should not say that.
Okay, sir.
Then let us say this patient has LV dysfunction.
Yes,
So
sir.
in your examination, how do you know whether this prosthetic valve dysfunction was associated with LV dysfunction or not?
Sir, so evidence of heart failure in the form of raised JVP or pedal edema is not present. The apex is localized to one intercostal space. So it is likely to be a dysfunctional apex is usually diffuse, sir.
Correct.
LV
It should
dysfunction
be
cannot be.
diffuse.
Yes, sir.
If it is LV dysfunction present, then it should be a diffuse apex and cardiomegaly,
Yes, sir.
right? Um, that also you have not mentioned. How do you know it is LV apex in your clinical examination?
Sir, an RV apex is usually diffuse. It is not localized to one intercostal space and it is present with significant lateral retractions. There is loss of medial retractions. Uh, it is associated with, we will have ancillary findings which suggest an RV apex in the form of pulmonary artery hypertension, like a loud P2, a parasternal heave, or a palpable P2. All of these would
So, okay. So how will you diagnose an LV apex by palpation?
Sir, a localized apex, an apex which is either in the normal position or shifted down and out, which is localized to one intercostal space and has medial retractions, would likely be an LV apex.
Lateral thrust medial retraction
Yes.
denotes an LV apex.
Okay. Okay.
Okay, now post-op aortic valve replacement 2016, redo surgery 2018, recurrent prosthetic valve thrombosis to roll out pannus, status post-thrombolysis, sinus rhythm, NYHA functional class 3. She had acute pulmonary edema, right?
Yes, sir, likely.
Yeah, acute pulmonary edema with functional class 3 improved. Now he's in which class?
So she has limited functional capacity. She is still receiving UFH infusion, so she is only walking till the washroom.
Okay. No evidence of heart failure, infective endocarditis. So pulmonary artery hypertension status you have not mentioned.
So there is no
And
evidence of PH.
you will not be able to mention it because you have not examined any RV impulse. You have not mentioned second left intercostal space also.
So there is no loud P2, there is no parasternal heave, and there was no palpable second heart sound. So it is less, and she has no significant history of dyspnea in her history. She has never complained of dyspnea. So And even in the setting of in her clinical setting, it is less likely that she would develop PAH.
Oh no, she is very high likely for to develop PH. Do you think this patient has pulmonary venous hypertension?
Sir, because she has recent history of decompensation for which she became NYJ3, she has history of orthopnea, and she probably went into heart failure recently. She has PVH, but that has resolved at this time with improvement of her heart failure symptoms.
PVH is resolving, but still PVH is there because she has a going only. She's able to go to the bathroom only and still symptomatic. Yes. So, what is your status about his? Evaluation of her mitral valve status.
Sir, her mitral valve appears to be normal, sir.
How do you know?
Sir, S1 is normal. There is no ancillary symptoms of dyspnea or shortness of breath in between. There is no evidence. There is no development of AF. There is no evidence of pulmonary artery hypertension. She's class 1 in otherwise, except this recent episode. And she has previously been evaluated at the age of 58, where she was told she had only one valve dysfunction. If she had both valve dysfunctions, it is possible that they might have treated the mitral valve also if it was a significant disease.
No, prior to prosthetic valve thrombosis, she had no symptoms. No,
Yes, sir. She was NYHA once.
that itself tells that there is no significant disease of the mitral valve. When do you get diastolic MR?
Sir, in heart failure, when LVEDP rises beyond LA pressures, even in diastole.
Which condition you get diastolic MR?
Sir, sir, acute heart failure will cause diastolic MR.
Which no, oh, so many acute heart failures you see. They are all develop diastolic MR.
Sir,
Only in one specific clinical situation they develop diastolic MR.
sir, acute AR can cause diastolic.
Acute severe AR. Acute severe AR. Only then you get diastolic MR. Otherwise you won't get. So diagnosis over. So this is you have to edit your diagnosis. It is incomplete. Okay, as we discussed. So what is it that you want to do? Which all tests you would like to do to confirm your diagnosis? Confirm or refute?
Sir, I would like to do an ECG and troponin. I would like. She is
Why?
all. Sir, because she is an elderly
Why
female.
ECG first?
Elderly female presenting with increased chest pain for the past 3 days. ACS should be ruled out, sir.
Correct. ECG is there.
Yes, sir.
Tell us about the positive findings and the diagnosis. Maybe just tell us the diagnosis.
So there is LVH with pressure overload. The patient is in sinus rhythm, normal axis. There is evidence of LVH by the Sokolow-Lyon criteria, and there is evidence of pressure overload in the form of T-wave inversions in V2 to V6.
Correct. There is LVH with strain. Why there is ST elevation in V1, V2? Is it there?
Sir, it is non-significant ST elevation, sir. It is related to repolarization abnormalities related to pressure overload in the lateral leads.
I don't think so. Why is it that LVH strain is showing T inversion and ST elevation in V2, V3?
Sir, it is less than. It is not significant, sir. It is less than even 1 m. It is less than
It
1.
is significant. It is significant. So it can be a reflection of LVH itself, but you should strongly consider cardioembolic
Yes, sir.
ACS because LVH with strain in V4, V5, V6, that kind of appearance is okay, acceptable. But V1, V2, V2, V3 is too much. V1 also can have some ST elevation in LVH.
Yes, sir.
But this V2, V3 small ST elevation and deep T inversions. See the difference in T inversions of V2, V3, which is deep, inverted, pointed, and symmetrical, which is actually a reflection of ischemia,
Yes, sir.
as against the V5, V6 ST asymmetric ST depression of strain. You got it?
Yes, sir.
So strongly consider.
Yes, sir.
Don't say it is normal.
Okay, sir.
What is the next test you would like to do?
Sir, troponin in this patient.
Okay, what was the troponin for this case?
Negative, sir.
Very, very surprising. It should have been positive.
Sir,
Be it
there is
ACS or a prosthetic valve, be it ACS or a prosthetic valve thrombosis, either way, the troponin has to be positive.
should be slightly raised, but she had two troponins done, sir, at admission and 3 hours later, and both were less than the cutoff of 0.05 in our lab.
I don't know prosthetic valve thrombosis they are raised. I'm totally surprised. What is the next test you would like to do?
Sir, our baseline blood investigations, including an INR and CBC, should be sent. A kidney function test should be tested to rule
Okay,
out.
let us say the INR. What do you expect this INR to be when the patient is acutely sick and there is prosthetic valve dysfunction?
Sir, if there is a long history, it is possible that the patient may develop.
There is no long history. Your history is only 3 days duration. This patient you have sent for INR. What do you expect the INR to be?
It will be subtherapeutic, sir.
Wrong. There is a good chance this patient will have very high INR. Why?
Congestion causing congestive hepatopathy may raise.
Yes. Acute heart failure will cause acute congestive hepatitis, and INR will be paradoxically high. And you will have to sometimes think twice before you lyse
Yes, sir.
because there is already a baseline high INR.
Yes.
And if you are having a normal INR, you are lucky, and the patient is lucky because that means there is no acute fulminant heart failure with congestive hepatopathy.
Yes.
So what was this patient's INR?
1.45, sir.
Really?
Yes,
Good.
sir.
What is the next test you would like to do?
Sir, an echocardiography and if possible, a synapse.
Okay. Okay. Which one you will do first?
Echocardiography. So patient is sick, bedside test should be done first.
Right. What all you will test for?
Sir, we have already ruled out a rhythm abnormality in the ECG. We will look for gradients across the prosthetic valve and look for if we have a baseline gradient, any change in the gradient. We'll look for LV dysfunction, which may be a cause in these patients. We'll look for any vegetation or obvious thrombus that we can see on the prosthetic valve.
Anything else? We
Sir,
will look for.
Why it is not because of paroxysmal atrial fibrillation?
Sir, a rhythm abnormality is an important differential in patients decompensating. This patient did not give any history of palpitations. If she had an AF with FVR, it should have been a prolonged AF with FVR with which she would have presented to us. But she has this history of 3 days, sir. However, arrhythmias are a common cause of decompensation in these patients, sir.
You have not mentioned the type of mechanical valve you will look forward. You look into it, okay? And this patient's ECG, this ECG is probably taken after the patient is stable because an acutely sick patient should be having a lot of tachycardia.
Yes.
This is not the first ECG.
Yes.
Right, it's okay. First ECG, was there AFib?
No, sir. She is always in
Only
sinus.
sinus tachycardia.
It is not in the
Okay.
file, but they have documented that there is sinus tachycardia.
Okay. So, so how do you see by echo quickly? This is prosthetic valve dysfunction.
Sir, we look at gradients or a change in gradient across the valve. We look at any new regurgitant lesions which are significant and not just washing jets. We can look at, so in stenotic evaluation, sir, we look for a mitral valve, we look at pressure half time. In aortic valve, we look at the peak velocity and peak velocity across.
So when, correct. So what kind of gradient is usually abnormal in an aortic valve? Let us say you never saw the patient. You're seeing for the first time. When do you say, oh, this is abnormal?
Sir, a mean gradient of more than 20 would be abnormal in an aortic valve.
Correct. And this patient, what do you expect the gradient to be?
Sir, at presentation, it was around 60 in the documented ECGs. Now it has normalized and mean gradient is less, sir. I'll show the echo
Yeah.
subsequently.
So you anticipate the mean gradient should be at least more than 40, right? When the patient is sick. Oh, you have the echo video. Please show the echo video.
Sir, this is the chest X-ray.
Echo. Please comment on the echo when you're okay, please comment.
Sir, this is showing a parasternal long axis view of the parasternal long axis view, which is showing concentric left ventricular hypertrophy. The mitral valve appears to be normal, and the LA appears to be normal. There is a prosthetic valve in position at the aortic valve. However, we'll need to look at subsequent views to define what sort of valve there is.
Is the valve functioning well in this echo?
Sir, it is difficult to say in this echo because it is in this view, it is not clearly seen, sir. There appears to be
But
some
it is actually moving.
Yes, sir. There appears to be some motion of
What
the
is that line you are seeing across the center of the aortic valve?
So that's an artifact.
Correct. Second video play, please.
Uh, so this is an apical four-chamber view, which is showing the mitral valve, which is showing normal LV contractility. The LV function appears to be normal. There is no obvious thrombus visualized anywhere in the LA or LV.
Are you expecting any thrombus in LA or LV?
No, sir.
Where do you expect the thrombus?
Sir, at the aortic valve position, sir.
Correct.
This is the apical five-chamber view, which is showing flow across the aortic valve, which is showing almost not. There appears to be slight restriction of one leaflet of the aortic valve. There is no obvious turbulence across the valve, and there is no evidence of any regurgitation across the valve. This is the
So what do you
gradient.
think with wait, go back. Which valve do you think it is?
Sir, aortic valve.
Yeah, obviously. Is it a tilting disc or a bileaflet?
Sir, it appears to be bileaflet, sir. There is one leaflet which appears to be not moving still.
But whatever it is, the leaflet what you are seeing is moving very well.
Yes, sir. One leaflet is moving well, sir.
And is there any regurgitation in the echo on the right hand side?
Sir, I could not visualize any regurgitation. I tried to tilt
In the
it.
video. In
Yes.
the video you are seeing, is there any regurgitation on the right hand side in color?
There is minimal, tiny regurgitation jet noted, which might be,
A tiny whiff. Is it normal or abnormal?
it is normal, sir. Washing jets are normal.
Yeah, it can be physiological. So there is no significant severe regurgitation seen. Next video, please.
So this is the aortic valve gradients.
Okay, please comment about it.
So the maximum aortic valve gradient is 25 and mean gradient is 13, which appears to be within normal limits. However,
Up
sir,
to what level you will consider normal gradient in an aortic valve?
sir,
In a prosthetic aortic valve?
Sir, a mean gradient of more than 20 would be abnormal. However, any increase in gradient from a baseline echo of more than 10 should be considered abnormal.
Yeah, right. If it is less than 20 gradient in aortic valve, you accept it. What is the mean gradient in a prosthetic mitral valve up to which you will think, okay, it's okay, we'll accept it?
Sir, 5 mmHg.
Up to, yeah, it's up to 5 to 8, 10 is okay. Up to 10 is okay. Beyond 10, we cannot accept in mitral valve.
Yes.
Okay. So this has a mean gradient across the prosthetic aortic valve of about 15,
Yes.
which you think is appropriately acceptable in the present clinical scenario.
Yes.
And it is understandable because the patient is clinically stable. And this is a future reference hereafter for future comparisons of gradients, right?
Yes, sir.
Yes. Next slide, please.
So this is an LV function. I would like to show that the patient also underwent a CT for evaluation of.
Please go back to -1.
So this is LV function, just showing that there is a normal LV function. There is concentric LVH.
Okay.
Yes, sir.
Right.
There is no obvious RWMA in.
So there is no massive MI that has happened, right?
Yes, sir.
So we'll have to see LVH is massive. That means the V1 ST elevation would have been related to the LVH, but the V2, V3 T inversion is probably maybe a more small cardiembolic ACS. We don't know. But you said you got a troponin of low
Yes,
or negative. So we'll have to presume that there was no cardiovascular event.
yes, sir.
So what is the next test you would do?
So next steps would be cine fluoroscopy to visualize opening angles of the valve.
Correct. Have you done it? Can I see?
Sir, I don't have the video of the cine.
So what did the CNA show?
Sir, one leaflet was stuck. The other leaflet was moving, was showed restrictive movement at the start and is now still showing restricted movement. One leaflet is still stuck, sir.
Okay. So it's a bileaflet valve.
Yes, sir.
Okay. Let us see. What is the next test to do after fluoroscopy?
Sir, in the setting, so we have to rule out, now we have to rule out the causes of recurrent prosthetic valve dysfunction and thrombosis in this patient. We have already found that she has subtherapeutic.
So to thrombolize a patient for a presumed prosthetic valve dysfunction, what all test you will do?
Sir, an NCCT head should be done to rule out previous ICH.
Did you do that?
Yes, sir.
Okay. Does the guideline say it to be done?
So we usually also thrombolize for MI. We don't do an NCCT head, but at our center we do NCCT head routinely before thrombolizing in patients who are not very sick, sir.
Okay. But it's good because sometimes if the patient develops some event after thrombolysis, we won't know whether it was there previously or not. I mean, since CT abnormality.
Yes,
If there's the obvious clinical event, it is quite obvious.
yes.
So let us see the CT.
So she subsequently, so we evaluated for eosinophilia as well, which is not
So what is
present.
the most important reason? Yeah, what is the most important reason you would do a CT?
So to rule out a thrombus, to rule out a pannus in this patient, to differentiate between a thrombus and a pannus.
So the best test to do to identify a thrombus is a CT.
Yes, sir.
So you have even if you have not sure the valve, sometimes the valve, if it is a stuck valve, totally stuck valve, it is very easy to pick up. Sometimes the valve will slightly move and you are not whether sure it is restricted or not. You can always say restricted, but it may not be restricted. And you can say normal, but it would be really slightly restricted. So you don't know the difference. So the best thing is to do a CT that will tell us clearly about thrombus, pannus, and the movement of the leaflets very clearly. Okay, and you can record it. So show us what you saw and what is your inference.
Sir, this is the CT which showed restricted opening angle of one leaflet, sir, which we can see on the left frame. In the right frame, we found a filling defect on top of the leaflet. The Hounsfield units of that filling defect were -30, which was suggestive of a thrombus more than a pannus. In a pannus, we usually expect Hounsfield unit of more than 145 that we have taken as a cutoff, and less than 90 would suggest a soft tissue density, likely a thrombus. So this CT was done to rule out a pannus, which is why the patient is now planned for further cycles of thrombolysis.
Yeah. So thrombus is your first clinical diagnosis from the presentation. So thrombus is nothing new, but you want to know additional pannus is there and any other complications related to that in the CT, right? So next.
So this is my last slide.
Okay. So how do you have an X-ray? Show me the X-ray, please. Okay, the X-ray we check for what?
Sir, we check for the which is the valve. So we look at the position of the valve. Other than that, we look at the cardiomegaly, any cardiac apex. We look at the pulmonary lung fields for any evidence of PVH.
Okay, so tell us about this X-ray. What are the positive findings?
Sir, this is a PA erect chest X-ray, which is slightly rotated.
No, demon level. Only positive findings you tell.
So
Don't describe the X-ray.
there is a metallic ring noted at likely the aortic position in this valve. There is no cardiomegaly.
How do you know it is aortic and not mitral?
So we draw a line from where the heart meets the right diaphragm from that point to where
Right cardiophrenic angle. Yeah.
right
To
cardiophrenic angle. Sir, to the left where the left to the left pulmonary base, sir, where the and where
left
the
hilum. Hmm.
left hilum, yes, sir.
Left hilum. Hmm.
Left hilum. If the valve is above this line,
And
sir, if the valve is above this line, it is likely to be an aortic valve. If it is below this line, it is likely to be a mitral valve.
so how do you differentiate between a tricuspid and a pulmonary?
Sir, I'm not sure, sir.
Do you have a lateral view of this?
No, no, sir, we didn't
Do you have a
do.
lateral view of this?
Uh,
Okay. So
yeah.
any other additional positive findings in this X-ray other than the valve?
Sir, there appears to be slight PVH. There is still some cephalization noted, sir. And on
PVH is there then?
uh, sir, the aortic shadow appears to be prominent. So she might have ascending aorta dilatation associated with her valve abnormality.
Yes. Prominent aortic knuckle is there.
Yes, sir.
You can see some aortic shadowing there.
Yes, sir.
You can see cardiomegaly. You can see LV type of apex probably, which has to be confirmed in the lateral view because in AP view it is not confirmed. You can only say probable because it is not an RV type of apex. There is pulmonary congestion. You can see that mottled appearance, ground glass, which is a reflection of the pulmonary edema not fully recovered.
So she
You
had
can see
underwent a
the
redo surgeries twice,
Yes, sir.
and there are no sternal cliffs. So what was the approach for the surgery?
Sir, both time it was done through medium sternotomy as per the patient. There are some clips
by
that
the
Sternal wires are not
what
seen.
is that? Sternal wires are not seen. Those are not sternal wires. Sternal wires are not seen. Why? Tell us why.
I'm not sure, sir.
So during an examination, did you feel any sternal wires in the patient's sternotomy scar?
Uh, Sir, I didn't palpate this car.
Why? It's routine. No, you feel it. Maybe it's not there. Sometimes the surgeons will remove it. It's optional. It's not mandatory. You have to remove.
Okay, sir.
Sometimes some surgeons remove it.
Okay.
And whenever you do second surgery, definitely you'll remove it second time. The first sutures, and then you put new sutures. And maybe they remove. We don't know.
Okay.
Yeah, even the X-ray is suggestive of an LVH, like a boot-shaped heart, if you can appreciate it, which
Yes.
is a reflection of severe LVH. The blood pressure was normal, so it's not hypertensive heart disease. It is actually the LVH of previous aortic valve disease that still is there.
Yes, sir.
So, what is your treatment strategy for this patient? Let us say this patient is acutely sick. What is your treatment strategy? Take a CTV as cardiac surgeon's opinion. Ask him if he is willing to do an emergency surgery. He will say this patient is high risk for surgery because critically ill. Please proceed with thrombolysis. So you will take a consent for the patient for a 20% risk of IC bleed and then proceed with IC bleed over plus minus a stroke and then proceed with lysis. You will do the slow lysis with streptokinase or alteplase, which is the choice in your center, and then you observe for resolution of symptoms. When do you stop lysis?
Sir, normalization of gradients and normalization of movement on cinefluoroscopy is when we stop lysis. Sir, but
Okay, so let us say, yeah, please tell.
there are no clear guidelines as to the endpoint for lysis. For example, in our patient, now the patient is good functional capacity. There is no significant gradient across the aortic valve. So, we are
So you stop lysis.
no, sir,
So you stop lysis.
we are planning to give her we are planning to continue giving her thrombolysis because we believe it is a thrombus. But since she is not a candidate for redo surgery because of multiple previous surgeries and poor functional capacity, it is possible we will have to accept some restricted movement.
But now you see the gradient as per your echo is acceptable range. So you can stop lysis.
Yes, sir.
Whatever job the lysis had to do, it is already done.
Okay, sir.
Okay, so you stop.
Okay.
And then what you do?
Sir,
Let us say morning 9 o'clock, I have stopped lysis.
yes, sir.
Your resident calls you and tells, sir, very good resolution of symptoms, no gradients, it's less than 20, 9 o'clock. So we say, okay, let's stop lysis. Then what you do?
We restart UFH, sir.
What
Unfraction.
time?
Sir, we started within half an hour at our center, sir.
Why?
Sir, because sir, the action of the altiplase, we do started within half an hour, sir.
Yeah. So you find out which agent you are using, what is the half-life, and let us say if it is streptokinase, you wait 4 hours, check one ACT, and once it is an acceptable range of less than 200, then you start UFH. And you start UFH and
Sir, if the patient is doing well, we are convinced, then we'll start warfarin as
this
well.
patient is stable. This
Yes.
patient is stable. You said no gradients, lying down flat.
Yes, sir.
Patient is doing well.
Sir, because there is still restriction of movement of the leaflets, we are planning to give her more thrombolysis, sir.
Okay, but the gradient is less than 20.
Yes, sir.
So you start warfarin and UFH.
Yes.
For how many days? Both together.
Sir, till the INR is in therapeutic range. So in this patient,
How much is the therapeutic range you want?
sir, in
This
this
patient.
2.5 would be for aortic wall, but she has previous history of recurrent prosthetic heart wall thrombosis, so we'll increase it to 3. Our target INR should be 3.
Yeah, 2 to 3 is sufficient. But the problem is this patient was not having a prosthetic valve thrombosis when the INR was optimal.
Yes, sir.
So you don't have to try to achieve more. You just try to achieve optimum.
Yes, sir.
And like sir said, time in therapeutic range is very important. You should have at least 75% time in therapeutic range with a monthly INR. That
Yes.
means out of 12 values, at least 8 should be in proper value.
Yes. Okay.
Any treatment needed for heart failure for her now?
Sir, her LV function appears to be normal. There is grade 1 diastolic function, dysfunction. I had put a slide on that. So if she persists to have dyspnea, then we can consider adding loop diuretics for her. But if she improves to class 1, then no treatment for heart failure.
What do you expect her NT-proBNP to be?
High, it is likely to be high, sir.
Why is that?
She had acute decompensated heart failure because of the prosthetic heart wall thrombosis.
Yeah, and she has LVH also, and good candidate for diastolic heart failure as well,
Yes, sir.
in addition to the prosthetic valve dysfunction, systolic heart failure.
Yes.
Yeah. Yes. Any other doubts?
No.
We have already crossed 1 hour. Dr. Mahajan, Dr. Kamal, some comments from your sides, please. Yeah, good presentation, Prerna. So please,
No questions from my side. It is excellent presentation.
yes, good presentation, and we appreciate it, and we expect and hope you will do a better job next time. You did a good job, but you can always improve, isn't it? So I will show a few spotters.
Thank you, sir.
Thank you. So before, we used to have a lot of cath data and other things. Now we are most of the times we focus on ECG, echo, and maybe cardiac MRI and other imaging modalities because we have become more advanced. So let us go through a few of the spotters, just a sample for just to make an idea. Whether you fail or pass is already finalized in your clinical case presentation itself, and spotters and viva just to assess your knowledge, and sometimes if there are multiple candidates to see who should be given the gold medal when there is a close competition. So let's go. 68 male presented. Can you see the slides? Prerna, can you see?
No, sir. The slides are not visible.
Oh, okay. Can you see now?
Yes, sir. The slides are visible.
Okay. So 68 male, easy fatigability, dyspnea, NYHA class 3, 1 month diagnosis.
Sir, should I answer?
Yeah, obviously.
Yes, sir. Sir, cardiac
Yeah,
amyloidosis.
5 seconds stance. Yeah, why do you say so?
Sir, there is pseudo-infarct pattern on the ECG. There is a concentric LVH. There is concentric biventricular hypertrophy. There is a sparkling appearance to the myocardium. And there is the GLS shows cherry on top appearance with apical sparing suggestive of amyloidosis.
Correct, good. Low voltage complex on ECG and LVH on echo. Good. This is cherry on tap pattern on LVGLS, and it indicates relative sparing of strain abnormalities at the apex of the left ventricle. This patient, 28, male, is pre-syncope. Diagnosis.
Sir, it shows same.
Right. Hypertrophic obstructive cardiomyopathy with SAM. Which
Yes.
gene is the commonest gene involved?
Sir, heavy chain myoglobin and titin are commonly involved most.
Myosin heavy chain and myosin binding protein C. Another case, 28 male, giddiness 15 days, syncope, diagnosis. This is the ECG on the left-hand side and MRI on the right-hand side.
Sir, ARVC.
Yes, right. Why?
Sir, ECG is showing epsilon waves, sir. There is repolarization abnormalities in the right-sided leads.
Correct.
MRI is showing.
And MRI?
The MRI is showing, it is a cine loop of the MRI, which is showing RV dysfunction and a dilated RV. There appears to be some segment of wall motion abnormality in the RV also, sir. And aneurysmal segment appears to be present.
What is the diagnostic MRI feature of ARVD?
Uh, Sir, we look for wall motion abnormalities and we look at the RVOT width and
Yeah. Fibrofatty infiltration, especially of the apex, that you can see there. Yet another case, 20-year-old male comes to us with syncope. This is the ECG and that is the image. What is your conclusion?
um, so this is gross concentric.
See,
Yes, sir. Infiltrative disease. So we will rule out congenital diseases like Cannon's disease and
correct, correct. And there is also pre-excitation on ECG. Okay, can you see that?
yes, yes, sir. Pre-excite.
Good. So, Dannon's disease,
Yes,
very high risk of sudden cardiac death. The refractory to defibrillators, you will need transplant before 20-25 years of age. Okay.
yes, sir.
And you can see how the MRI will differentiate between hypertrophic cardiomyopathy, Fabry's disease, amyloid, and Dannon's disease. In amyloid, you have diffuse subendocardial enhancement, right?
Yes.
Good. Another case, 23 female, giddiness, heart disease in childhood. Diagnosis?
Which is- Uh,
You have ECG and echo together, so it's easy.
Sir, she has a congenital heart block which is present, sir. She has a
Correct.
DDD. A pacemaker is present in C2. Yes, sir.
Correct. So this is a complete heart block for which a pacemaker is put. You can see in the echo, the right-sided ventricle, the right-sided AV valve is not apical. Usually you expect the tricuspid valve to be more apical, right?
Yes, sir.
Here you see the right-sided AV valve is not apical. The left-sided AV valve is apical. And the
Yes.
left-sided AV valve is having some septal attachment. So it is a
Tricuspid.
corrected TGA and
Correct.
Epstein's anomaly with severe regurgitation. Okay.
Yes, sir.
Good. Now, this one. 56 female comes to us with diarrhea and wheezing frequently last 2 months, which is hotter than something like perimenopausal.
Yes, sir.
But this diarrhea and wheezing is unusual. What is your diagnosis?
Sir, carcinoid syndrome. It is in
Correct, carcinoid. So the tricuspid valve is fixed and immobile, very typical of carcinoid, isn't it?
yes.
So was the pulmonary valve. Correct. Which test would you do for this case for confirmation of diagnosis? Blood test.
Sir, 5-HIA is usually done in 24-hour urine, or plasma 5-HIA is done, sir.
Correct. Please tell the full form of HIAA.
Uh, Sir, it is indole acetic acid.
Yeah, correct. 5-hydroxyindole acetic acid.
5-HIA. Yes.
Now, what is this?
So this is a bicuspid aortic valve.
Oh,
Yeah.
there is a tendency to say it is a bicuspid aortic valve, but look closely, it is actually quadricuspid aortic valve. Can you see that?
Yes, sir. Yes, sir.
Are you able to appreciate the forecast?
Yes, sir.
Good. Now, this is the classification, the Hurwitz and Roberts classification of quadricuspid. Even if you don't say the name, it is okay, not easy to remember. Okay. What is this patient? Treatment of heart failure, 68 male, comes with extreme fatigue and giddiness. What is this rhythm?
Sir, there is ventricular bigeminy noted. It is most likely due to this is bidirectional VT, sir. It is most likely due to digoxin toxicity.
Correct. This is bidirectional VT and digoxin toxicity. Another patient. What is the diagnosis? Comes with us with palpitation. This is easy.
Sir, there is a wide complex tachycardia noted, which appears to be regular. The axis is northwest axis. There is evidence of AV dissociation noted in the rhythm lead. There is slurring of the upstroke in AVR present. V3 shows what appears to be a fusion beat also. It is likely to be a VT, sir.
Negative concordance V1 to V6.
Yes, sir. There is
Can you
also.
appreciate?
Yes, yes, sir.
Deep and wide S in V5, V6. Can you appreciate?
Yes, sir. Yes.
All these say VT. So most of the times it is easy to say VT, but you should at least have 3 points to favor from your ECG. Why do you say VT? Okay.
Yes.
Okay. This patient had a recent abdominal surgery. He was breathless. His troponin was high. He
Yes.
had LV dysfunction. So we did an angiogram. It was normal coronaries, and somebody did an LV angiogram, which is common in Europe and UK, but not very common to do in India unless specific conditions. What is your diagnosis?
Sir, Takotsubo cardiomyopathy.
Correct. The apical ballooning or stress cardiomyopathy, isn't it?
Yes, sir.
Same, you can see there. In the echo also you can see. Most of the times it is diagnosed by echo. You don't need an LV angiogram, but when you want to show something like this, sometimes we take an LV angio, isn't it?
Yes.
What is this ECG?
Sir, the patient has developed torsade, sir, in the ECG.
Correct. Tosa de ponte is there.
Yes, sir.
Anything abnormal?
Sir, there is
That will
there are presence of likely U waves in the ECG might be related to
right. There is U and there is QT prolongation.
Yes.
All correlate to?
Sir, hypokalemia causing.
Correct.
Yes, sir.
Hypoglycemic calling. Correct. Very good. What is the diagnosis of this case? This patient, they call you from emergency and say this patient's BP is 80, breathless, and this is the ECG.
Sir, this might be related to hyperkalemia, sir. There is widening of QRS present.
Correct. The TV becomes taller, the QRS becomes more and more wide, and finally you will end up with something called a sine wave when very high potassium levels, like more than 8, 8.5 is there. And you can see in AVR, it looks like a sine wave, isn't it?
Yes, sir.
Good. What is the diagnosis of this ECG? Brother died sudden cardiac death. So the younger son was brought by parents. We took an ECG and this is the ECG.
Sir, this is Brugada syndrome, sir. Gene involves.
Correct. What do you say, Brugada?
Sir, there is Saddleback.
Why do you say Brugada?
So there is saddleback, ST elevation, and the precaudal.
This is not saddleback.
There is
This is not saddleback.
yes, this is type 1 Brugada, sir. There is ST elevation, which is down slope. So there is
Coving type. Yeah.
coving.
This is incomplete right bundle branch type, ST elevation in V1 with coving type. So it's type 1. Right. Saddleback is type 2. This is not saddleback.
Yes.
Gene is SCN5A gene. Okay. This is a 2-year-old child, came to us with heart failure. This is the ECG and this is the echo. What's your diagnosis?
Uh,
Q in 1 AVL.
yes, sir.
Loss of R in V4,
Alka.
V5, V6.
It is likely
Huh?
It is likely
Correct.
Alka.
Al-Kappa. Correct. Very good. Al-Kappa.
Yes, sir.
Yet another patient, 49 female, ankle fracture, acute onset breathlessness, BP 76, oxygen saturation 78. Diagnosis.
Pulmonary thromboembolism.
Correct. Acute massive pulmonary embolism with the RV dysfunction. Good. And what is this?
Mm.
Where is the catheter?
So pulmonary artery. We are doing pulmonary artery angiogram, sir.
Correct. This is a pulmonary angiogram. What does it show?
Mm.
Can you see it is not filling very well? There is some intraluminal opacity,
Yes, sir.
which is actually a filling defect. This is thrombus.
Okay. Okay, sir.
This is the same patient, sir.
Okay,
They
sir.
refused lysis,
Yes, sir.
so we had to aspirate. So we are doing aspiration. We have this penumbra catheter through which we aspirate. Okay, this is the penumbra system.
Okay, sir.
You have to go to each branch and aspirate. So you get the aspirate like this. Clots.
Yes.
The end point of aspiration is when your saturation becomes normal. As soon as you do the procedure well, the patient will have normal saturation, BP will improve.
Okay.
But you have to go through each branch and do it. Okay.
Yes, sir.
This patient, a 12-year-old male, presented with breathing difficulty while playing. What is the abnormality?
So this is coarctation of aorta, sir. There is
Correct. Which
diastolic.
gene?
Not sure of the gene. Not sure.
Correct.
Yes, sir.
Can you appreciate the bicuspid aortic valve, which is a common association with coarctation?
Yes, sir.
Good.
Yes.
This boy came to us with some skeletal abnormality. Can you appreciate it? The skeletal, the hand abnormality and the X-ray.
Yes, sir.
And
This
then what is your diagnosis? And that is echo.
Halter arm syndrome, sir. There is.
Correct. This is Holter arm.
Yes, sir.
And what do you see in Holter arm? Cardiac abnormality.
Mm,
In the image, what abnormality do you see?
so there is ASD in this image.
Good. Right. Next, another patient, 11 years, he came with dyspnea. This is a continuous murmur. What is your diagnosis? You can see the two great arteries. There is a defect in the communication, you see, and there is a shunt. Can you see that?
Yes.
What is it?
AP window, sir. No.
Correct, AP window. Most of the time, it is very unusual. By the time they are 11 years, they would have had severe PH.
Yes.
But this was very unique patient where she did not develop PH. So this is what we did. We did a CT, we did a 3D reconstruction, and this is how we saw that AP window. Can you see that in the angio as well?
Yeah.
Yeah, and we did a device closure. It was a very rare case, and we published it. Another case, 6 years, a male child, shortness of breath. What is your diagnosis? You have the MRI. This is how his head and the hands look like, and the feet. That is echo.
Sir, I don't remember this condition. I know.
Good. It is Naxos
Naxos
disease with
disease,
woolly
yes.
hair, keratoderma, and ARBD. Okay.
Naxos.
It's a relatively newer disease, isn't it? So it's worth noting.
Yes, sir.
It is autosomal recessive and it's a plakoglobin gene.
Yes,
This
sir.
is what we used to face during our DM exam. What's your diagnosis? Maybe we'll skip this. Let us see something else. Okay, this patient is an adult 65-year-old male with
Yes.
angina. You can see, tell us, describe the angiogram, please.
So there is
There is an injection in the RCA, that is the first image. It is ectatic,
yes,
and
sir.
it is giving collateral to the left system. Agreed?
Yes, sir.
Okay. The second system shows an angiogram on the left side. It is empty. It is not showing any ostium, right?
Yes, sir. It is
And on the third injection, you can see that the vessels are all draining from the right through the collaterals into the left, and from the left mean it is going into some big artery. Can you see that?
yes, sir.
What's your diagnosis?
Uh, Sir, is this also Alcapa?
Also,
Alcapa,
this is
sir.
Alcapa.
Yes, sir.
This is a 65-year-old Alcapa, the oldest Alcapa alive. What does this JVP show?
It's a
Is it
Canon.
JVP or is it carotid?
So this can be JVP showing Canon waves due to
Correct. Right,
EVT.
right. It is between the two sternocleidomastoids, isn't it? We used to have a lot of these questions before. Nowadays, we don't do much, but this is very interesting. What is your diagnosis?
Uh,
This you should remember.
yes. So there is the same saturation in all four chambers. So this is an admixture physiology, sir.
Which one? Almost same, isn't it? 85, 86, 84, 87.
Yes,
So
sir.
TPVC.
TPVC. Yes, sir.
This
Yes.
one? This is another one that is classical.
Sir, this is PGS.
Aorta, RV, same pressures. Aorta, LV, RV, same pressures.
Yes, sir.
LV,
LV.
RV, aorta, PA. So this is the top, okay?
Off. Okay. Yes, sir.
I think that's it. We'll stop here. We have no time. We have crossed 25. Thank you very much. Nice being with you all. And I also had a nice time and learned a lot. Hope it was useful for you too. Dr. Kamal, please take over, please. Thank you very much.
Thank you, Dr. Tom. That was wonderful session. Amazing session. Very beautifully done and very good case presentation by Dr. Prerna as well. So I must thank you and congratulate Dr. Prerna. Thank you, Dr. Tom, for wonderful time and wonderful meeting. And I hope this brings us to the end of one more series and hopefully to have you all across for another series maybe by next year before the exams. So thank you, everyone. You can have this video uploaded and be viewed again for learning as a continuous process. And thank you again, Dr. Tom, for a wonderful session. Thank you, everyone. Good night. Take care and stay connected. Bye-bye.
Thank you.